teacher, and leader in dermatology with an exceptional record of national and international service. She has served as the president of Sri Lanka College of Dermatology and Aesthetic Medicine and is the current secretary general of the South Asian Association of Dermatologists. And Dr. Indira contributes significantly to global dermatology and public health, serving as a member of the WHO Technical Advisory Group on Leprosy and as counselor of the International Leprosy Association. She also plays a key role in postgraduate training as she works as the secretary of the Board of Study in Dermatology from 2024 to date. And we are truly honored to have her with us today. Please join me in warmly welcoming Dr. Indra Kahawita for her presentation. Over to you, Dr. Indra. Dr. Indra, can you hear me?
Yeah.
Hello.
Can
Dr.
you hear me?
Indra?
Yeah, Maitri, can you hear me?
Yes, we can hear you now.
Right.
Yes,
Okay. There was a small issue regarding my connectivity. So I'll
no
start
problem at all.
sharing.
Yeah. And please keep the mics mute.
Oh,
All the participants, please keep the mics and videos mute. Please.
मैं සූම් එකක් යනවා මම ඒක ඕපන් කරලා බැලුවේ දැන් මේ මම අතුල මේ එහෙනම් අර විදිහට කරමු එයාට මම අහන්නම් එයාගේ හා අර මේ වහරි වැඩෙත් එයාගෙන් අහන්නම් හා
uh, can we have the mics muted, please?
බලමු හා බලමු
Yeah. Can you see my screen now?
Yes, we can see.
All right. Okay. So before I begin, I have to thank the college for giving me this opportunity to talk to you on this very timely topic. So basically, I will be speaking on all the superficial fungal infections, but my main emphasis is on tinea or ringworm infections, or scientifically put, uh, dermatophyte infections. So let's first see what are superficial fungal infections, and then the current situation in Sri Lanka, the clinical mycological profile, and the management. Right? So, what are superficial fungal infections? They are infections of the skin, hair, nails, and mucosal surfaces by dermatophytes and yeast. So, if you can go back to your microbiology knowledge, dermatophytes are filamentous fungi or molds, whereas dermatophytes are filamentous fungi, and then we get yeasts, which are the circular organisms that you all know. So, out of these yeasts, Pityriasis versicolor and Candidiasis are uh, caused by yeast infections, whereas tinea or ringworm, scalp infections like tinea capitis and curion, and nail infections are caused by the dermatophyte fungi. So, what is the prevalence of fungal infections in Sri Lanka? So, if you have a good look at what you see here, right, you can see that you can see that we have data from a long time ago. Just give me a moment. Yeah, so you can see that we have had clinic attendance data for more than 50 years. And even in the 1970s and 80s, superficial fungal infections, even though they were the second commonest entity, they did not comprise more than around 10 to 12%. But then after that, in my polynerval study, which included more than 11,000 patients, the prevalence was around 7%. Then you see it's rising. It has almost doubled to 13.6% in my homogamous study in 2017 to 19, and NHSL just 1 year from 1st of August to 31st of July 2025, 1st of August 2024 to July 31st this year. You can see that tinea only comprised 19.3%. So that means all superficial fungal infections have surpassed the 20% mark in clinic attendance at NHSL. This is the same for all three units. This is only for my unit at NHSL. So this is more or less the same for all three units. So you can see that 1 in 5 patients that we see at the premier dermatology clinic in the country come to us with tinea, right? So this is the sorry situation that we are in at the moment. That is why it's extremely important that every doctor should know how to diagnose and manage tinea, because there is a lot of mismanagement. And can you please unmute your mics? Huawei phone, can you please mute yourself? Or
Can you please unmute your mic?
yeah, right. Okay, so so this is why it is important that all general practitioners know how to diagnose and manage tinea, right? Right. So tinea infections are becoming a serious health problem. Now, the 20% mark is like for the first time in decades. And you can see that all the previous studies group all superficial fungal infections together. This time I took tinea separately because I wanted to see what the burden of tinea is in Colombo. So our prevalence is 19.3%. And according to our data, the majority of the persons affected were in their late teens, young people, and the peak was at 17 years of age, right? And most of these patients needed oral antifungal therapy and itraconazole at that. And our cost for itraconazole is huge. And we see several family members being affected. So we, like in the clinic, when they come for the first time, we see 3 members of the family seated together, seated at the same time with me and the registrar and the senior registrar. And so that is the situation of the tinea infections in this country, right? And also we do see extensive involvement. So what are dermatophyte infections? Dermatophyte infections are infections due to filamentous fungi. There are 3 major genera, trichophyton, I forget the other 3, right? So anyway, there are, can you please mute yourselves? Right? Um, so, dermatophyte infections are due to three major genera, and out of those, trichophyton is the major organism that is causing tinea in this country. And tinea infections are named according to the area of involvement. So, if it is in the body, we call it tinea corporis. Hair or scalp, it's capitis. Face is fasciae, likewise. So, tinea cruris is one of the most important entities that we see in the country. You will see as we go further why I'm calling that a very major entity. The uncommon ones are tinea manum, which is involvement of the hand, or tinea pedis. Tinea pedis is not that uncommon, and the other one is onychomycosis, the infection of nails. So this is the situation that we see in Sri Lanka now. Multiple lesions, large multiple lesions, including the trunk and the limbs, right? And whether they are males or females, it's the same. Or tinea fasciae, like what we see here. Now, of course, here you can see the clear edge. But by the time most of our patients, now here you can see in the forehead, the edge is clear. There is a very good demarcation. And even in the second picture, you can see a good demarcation, a clear cut border. But when it comes down, you can see that it is getting somewhat blurred. The margins are getting blurred. And also, can you all notice, can you all observe that the earlobe is also in? So someone like her, especially this young girl, there is no way that we can manage her with topical antifungals alone. She is going to need oral antifungals definitely. So tinea fasciae is a real challenge for us. Then the tinea cruris, the commonest area to be involved is the groin, right? And then this is the uncommon presentation of tinea manum. Here you can see the scaling and the redness of one palm, whereas the other palm is completely normal. Or tinea pedis may present like this, the maceration of the toe web spaces, and it's very common to have see this in the web space between the fourth and the fifth toes. Right? So how commonly are these areas involved? This is data from a small study that I did over a period of 3 months at Base Hospital Homagama, where I worked from 2016 to 2020. You can see that the vast majority, 2/3 of our patients had tinea cruris, right? And face was seen in only about 15%, and trunk involvement was there again in 250%. 2 in 5 patients had involvement of the trunk, right? And you see that the total is not adding up to 100 because many of them had multiple sites being involved. And also, the incidence of tinea capitis and tinea pedis also has increased over the time. So, when I was in Homagama, we had this. I had to be involved in an outbreak in a university hostel. This was a government university hostel. There were so many young people with a groin rash in the hostel of a state university, and they were mostly males. You can see that 77% were males, and the average age was like around 23. 2/3 of them, 60% of them admitted to having a scaly rash. I mean, out of 61 respondents, 60% of them admitted to having a scaly rash. So actually, this was done while I did a awareness program, a lecture for them. And while I delivered the lecture, I distributed a small questionnaire in Sinhala and English, and this is how I got this data. Out of the 37 who admitted to having a scaly rash, 35 were males, right? So from the respondents, it was 77%, but the vast majority who had the rash were male. The average duration of the rash was about 5 months. The flexures were involved in, like, out of 30, 27 had flexural involvement. But 10 had multiple site involvement. Out of the 27, right? So you can see that multiple site involvement was like this, and treatment seeking behavior, the vast majority had gone to, the vast majority had been to a pharmacy for a treatment. So usually what happens is, now you see the majority have a rash in their groins. And the majority go to a pharmacy for their first treatment, the first contact. So if you had a rash, what you would do, what would you do if you were to go to a pharmacy and ask for treatment? Usually they would go and ask for a cream for a itchy rash. Hasana rash ekata behetak den. Because I don't think anybody will be brave enough to say that mage ekili kahanawa mata rash ekata cream ekak. Right? So generally what the pharmacy guy would do is they would dish out a combination. So during this time, 2018, all kinds of combinations were available in the market. So most probably they would have taken a combination or a steroid. So we come to the organisms causing tinea, right? So this is data from the 1970s and the 1990s. So over a period of about 20 years, you can see that trichophyton rubrum, which was the major, like 80% were due to trichophyton rubrum in the 1970s, but by the 1990s, it came down to 50%, whereas trichophyton mentagrophytes, which was less than 10%, rose to almost 15%. This is in the 1990s, and it is getting worse. So this is data presented in 2019 at our annual academic sessions. 61% coming with trichophyton mentagrophytes, which is a more zoonotic organism and also known to be less responsive to antifungals. Then in 2018, the college conducted an island-wide study including all 9 provinces, 796 patients. Predominant dermatophyte isolated was trichophyton mentagrophytes, 65.6%. So 2/3, now starting from 8% in 1970s, trichophyton mentagrophytes has grown to 66% in the late 2000, the second decade of this millennium, right? So that is the most difficult thing that we are facing now. And also, there were partial responders after 10 weeks. After 10 weeks of treatment, there were partial responders, right? And recurrence was also common, right? And those were seen more commonly in the group that had used topical steroids. And again, you can see that 63% had evidence of prior use of topical steroids. So 2/3 had multiple site involvement, 2/3 had evidence of previous topical steroid use, and 2/3 had evidence of what? Trichophyton pentagrophyte. So you can see how we have been promoting the emergence of a superbug. Things got worse. Now, after the COVID-19 was not the only new organism that started hitting us in 2020. Trichophyton mentagrophytes, ITS genotype 7. So Trichophyton mentagrophytes has 3 or 4 genotypes. Out of them, this genotype 7 is this organism that was earlier called genotype 7 was later proven to be a new organism. It is spreading rapidly worldwide, and unfortunately, it can be proven only by PCR techniques. And it's known to be resistant to terbinafine. The alarming rate is 70% of trichophyton mentagrophytes are not mentagrophytes, the Indochinae is likely to be resistant to terbinafine, oral terbinafine. And also multiple antifungal resistance is known. So this new organism, which was named Trichophyton Indochinae, this name is hotly challenged by the Indians, saying that it did not originate in India. However, what is our situation? Now, from our sample of some 700 odd scrapings, we were able to send 10 randomly selected samples for genetic studies in Germany. And you can see that of these 10 samples, 7 were Trichophyton mentagrophytes, Trichophyton interdigitale complex. Again, something similar to what we see in our culture studies. And the PCR was positive in all cases tested, and Trichophyton Indochinae DNA was detected in 5 of 10 samples. So out of the random 5 that we sent, a random 10 we sent, 5 had the positivity for Indochinae. So we can safely assume that we are harboring a tinea epidemic, which is caused by this superbug. So if what is the reason for this superbug? Now, if you think about the use of topical steroids, I think I need to use the word abuse, the abuse of topical steroids. If you can go back to your if you can go back 20 years or 25 years, those of you who have been in the service for the past 20 years, can you all remember this combination of steroid, antifungal, antibiotic creams or ointments started coming into our market in around the year 2004-5. When I started as a registrar, I was not familiar with this triple combination. But when I was working as a acting consultant in 2005, there were some triple combinations in the market, right? Then like the combinations increased in number as well as the combinations that were available. Initially, it was betamethasone, miconazole, and gentamicin, but then there were so many combinations of clobetasol, gentamicin, and miconazole. And it was easy for doctors also to treat because they thought, okay, this combination is going to work. Whether it is fungal or, whether it is infectious or anti-inflammatory, this will work because it contains 3 ingredients. But actually speaking, it is only the steroid that works. So what happens if you use steroids on your skin? You know that our skin also acts as a immune. Uh, I mean, there is an immune function, or I mean, the first defense organism in our body is the skin. So, and steroids, you know, are anti-inflammatory, I mean, it reduce. They are immunosuppressants. So, when you use an immune suppressant on the skin, that causes reduction in the skin's defenses. So, on the other hand, they are anti-inflammatory. So, the itching, the redness, the scaling of a fungal infection will be taken care of by the steroid. The more potent the steroid, the quicker the response. That is why the combination of clobetasol, miconazole, and gentamicin was used so widely by doctors and pharmacists and patients because they got better. I mean, better. They felt better with this because the clobetasol was exerting its anti-inflammatory action in a big way. At the same time, with the clobetasol, you are bringing down the defenses of the skin. So you are reducing the inflammation and you are reducing the defenses. That allows the organisms to multiply freely and invade the body in a more aggressive manner. That is why we started seeing very high numbers of tinea infections together with the increased use of steroids. Can I please ask you to mute yourselves? I have been muting so many of you. Right? Can you please unmute and stop your videos because it's very disturbing. Right? So from tinea infections, the ringworm infections, we move on to the involvement of the scalp, tinea capitis. Here you can see the tinea capitis is usually seen in young children, commonly seen in young children, and it presents as breakage of hair, like area of loss of hair, but you can see broken hairs. So this is the typical presentation of a gray patch tinea, or it may come like this, where the differential diagnosis would be alopecia areata. So tinea capitis is commonly seen in young children. When it is due to mostly animal fungi, you end up having inflammatory tinea capitis or chirion. Again, most commonly seen in children, but unfortunately, So let's talk about the organisms causing tinea capitis in Sri Lanka. Most of the infections were due to trichophyton mentogrophytes. So this is again not a very good thing, but you can see that more or less the same organisms were causing tinea capitis in Sri Lankan children, whether it was in the 1970s or in this millennium, right? So 2010, 65, the organisms isolated were again Microsporum, Gypsium canis, and Trichophyton mentogrophytes. We usually did not consider tinea capitis, even as dermatologists, considering tinea capitis or chirion as one of our differential diagnoses is not very common. That is because adults rarely develop tinea capitis. But recently, we have started seeing more and more cases of tinea capitis in adults. I, I will give you two examples. One was a young woman who had been treated with topical steroids and topical calcineurin inhibitors for an obvious case of alopecia areata. When she came to me, she had a few more patches of areas of patchy hair loss with scaling. The scaling was very evident. And I thought, I also stepped up my steroids. But she was getting worse and her hairs were getting matted together. And like even with stepping up steroids, she was not getting better. So I like empirically started her on itraconazole orally and everything clear. So you see, it was a case of tinea capitis. And again, one of our patients who was on treatment for scalp psoriasis developed multiple chirions, multiple inflammatory nodules on her scalp. So both these patients were on topical steroids on the scalp. You all know that there are so many topical steroid lotions that are available in the market, starting from Desonide. We have Desonide, Mometasone, betamethasone plus salicylic acid, clobetasol, and clobetasol plus salicylic acid. So at least, five or six topical steroid lotions are available. And every case of dandruff, who is not responding to the anti-dandruff shampoos, we are now in the habit of starting them on a steroid lotion. So the abuse of steroids, especially, don't forget that scalp lesions are very difficult to diagnose because you don't see it. You try to diagnose with the history alone, right? Because the hairs are covering the scalp, so you don't see the lesions unless the patient comes after the haircut. So, the other thing is tinea faciae spreads to the scalp. Tinea faciae is getting more and more common. So, because of these two reasons, tinea capitis in adults is being now diagnosed. So, don't forget that as well. So, if your patients with dandruff are not getting better with the anti-dandruff shampoo and a mild steroid lotion, don't step up your steroids. Refer them to a dermatologist. Coming to onychomycosis, these are the types of onychomycosis that we see. Here you get the distal subungual onychomycosis. This is superficial white onychomycosis. And you get complete destruction of a nail here. Okay. And onychomycosis, when we started dermatology, the teaching was that most of these are due to dermatophytes and glycofulvin was our first line treatment. But now the organisms are changing, right? So in this study, which was published, I have lost the year. This work was done in the I think from 2005 onwards, right? Mycological findings were positive in 66% and non-dermatophyte molds, Aspergillus and Fusarium, and other molds comprised of 46% of the organisms that were isolated. And dermatophytes consisted of only 20% and Candida species, albicans as well as non-albicans comprised of 35%. Again, a more recent work from the diabetic clinic at NHSL, Aspergillus species were present in 71% of the positive isolates in diabetics. And they had multiple toenail involvement. So you can see that even tinea, the fungal infections of nails are becoming more and more difficult to treat. Now, you know, if you go back to your pharmacology knowledge, you know that moles, the non-dermatophyte organisms, the moles, Aspergillus, Candida cannot be treated with grisofulvin. Grisofulvin has no action against yeast or moles, right? So you see that grisofulvin is becoming less and less effective because the organisms are changing, right? Whether it is only actually useful at the moment for the scalp, right? Coming to the commonest, probably the commonest superficial fungal infection, pityriasis versicolor. There are two different clinical presentations, the hypopigmented variety and the hyperpigmented variety. When coming to candidiasis, there can be different clinical presentations. You can have cutaneous lesions, you can have oral lesions. So oral thrush and cutaneous lesions, especially the Candida intertrigo, the involvement of flexures, you can see that it's more an erythematous lesion with pustules and satellite lesions presenting around the main lesion. And then, of course, you have the genital lesions, the curd-like discharge in Candida vulvovaginitis and the balanitis or balanoprostitis in males. So again, don't forget, if you have a patient with Candida genital infection, if they have a sexual partner, both partners have to be treated. And also, any male coming with Candida balanoprostitis has to be tested for diabetes. Don't forget these two very basic principles in the management of Candida infections in the genitals. Right? So how do we diagnose fungal infection? Most of these are a clinical diagnosis, but don't forget that the clinical picture may be changed by steroids, leading to tinea incognito. So you may do fungal studies in case of a difficulty in diagnosis, or if you think of resistance or recalcitrant lesions or nail infection. What are the samples that you can take? You can take skin scrapings, or in case of nail, you can do nail clippings, and mucosal swabs also can be taken. Then the thing is, if you go for fungal studies, you have to stop using topical or oral antifungals for 2 weeks before taking the sample. But it is very difficult to do that because the patients are symptomatic. Unless it is nail involvement, you find it very difficult to do fungal studies. So when we take samples, we go for both direct microscopy and culture, and to call it a proper infection, you need to have both microscopy and culture positive. Right. So how do we manage superficial fungal infections? Before that, you need to know a little bit or refresh your knowledge a little bit on the pharmacology of commonly used antifungal drugs. So grisofulvin is the commonest and it is effective against dermatophytes, but it is not effective against yeast. So therefore, it's useless in pityriasis versicolor and Candida. So when you do your OPD shifts or when you see your private patients, don't give grisofulvin to an obvious pityriasis versicolor. Then fluconazole. Fluconazole is usually the favorite of most GPs because it's easy to administer and it is less expensive. And also it is the least hepatotoxic drug out of all the antifungals. But unfortunately, its effectivity is mostly against yeasts. So griseofulvin is useless against yeast and fluconazole is very useful against yeast. Its effect against dermatophytes is very low, very, very low, right? So if you think of treating somebody with a dermatophyte infection with fluconazole, simply because it's easy to administer, think twice, right? So then come the itraconazole and the terbinafine. Itraconazole is more or less effective against almost everything. Dermatophytes, yeasts, candida, versicolor, onychomycosis. You can treat anything and everything, right? But when it comes to terbinafine, its action against yeast is not very good, right? So we don't give oral terbinafine for pityriasis versicolor or vaginal candidiasis. So remember this, right? Okay. So what are the challenges in managing superficial fungal infection? Treatment failures are being reported more and more. We don't have clinical trial data or sensitivity data, but there is an ongoing study of sensitivity patterns of dermatomyositis. But for the time being, what we can assume is that there is non-responsiveness to treatment. So you may have noticed that they don't respond that well to miconazole and oral agents like griseofulvin. There are several possible factors. One is the causative organism is now different. And then if you use steroids and steroid combinations, that may contribute to this. And then the poor compliance. This is twofold. One is you ask the patient to apply it, but they don't do it. Or the doctor gives only for 2 weeks. I mean, the major challenge when you are using antifungals, oral antifungals, is they are extremely expensive. So you don't feel like prescribing some. But then again, there is another universal truth that you need to remember. If you give them something which is less effective, the organism is very likely to come back. In that case, the patient will have to spend again on a better course of treatment. So this is what some people say, poor pay twice, right? So you first use a less expensive one and then you go for a more expensive course, especially you try fluconazole, they get better for a short period, but when they come back, you have to again spend on itraconazole. And of course, resistance to available medications is also a factor. Unfortunately, only a limited number of newer antifungal agents are available, and almost all of them are topical. Yes, we do have voriconazole, but voriconazole is not recommended for the use in dermatophyte infections in the immunocompetent patients. This is only limited for the use in immunosuppressed patients, right? So, out of the oral antifungals that are available in our market, itraconazole, terbinafine, and griseofulvin are the three candidate drugs that can be used for dermatophyte infections, right? So this was again a small survey done by our current president of the college. This was again done about 6 years ago. So when it comes to primary care doctors, you can see that most of them prefer to use fluconazole as their preferred oral agent in the private sector, whereas dermatologists were going for itraconazole and terbinafine even 6 years ago. Right? In the hospital, of course, we were using mostly grisofulvin at that point because it was the only thing that was available. Right? And almost 2/3 of the primary care doctors thought that they were not fully confident of a diagnosis of a fungal infection. 60% of primary care doctors admitted to adding a topical steroid. The reasons were not certain, right? And mostly it was 1% hydrocortisone and betamethasone, right? And 88% of the dermatologists and almost like about 50% of the primary care doctors admitted that there was a lack of therapeutic response to treatment of dermatophyte infection. This was in 2018, right? Unfortunately, only 2/3 thought they would refer to a dermatologist in case of a recurrent or recalcitrant fungal infection. And both groups, even then, thought primary care doctors need education on managing dermatophytosis. That is why it is important that we hold this sort of educational activities regularly. This is actually these two pictures are a little bit old. Most of the products are not available in the market now, but these are like from the Behet Malla that two patients brought to me. And so you can see how many different things they have been used, right? The ubiquitous Endem GM, Beclamin, huh? Gentacort MF, all these are triple combinations that they have been using. So what does this tell us? It tells us that doctors have been changing treatments or they may have been taking different kinds of treatment. So from my study at Base Hospital Homagama over 3 months, we found that 45% had used a steroid previously, and it was either betamethasone, triple combinations, or double combinations. Right? So that is alarming. The university students, again, they had used triple combinations as local applications, and for oral medication, they had taken fluconazole. Right. So the use of combinations and steroids can give rise to tinea incognito. Now you see, you saw earlier, you saw the typical tinea, a typical naive tinea that gives rise to a nice border and a large patch. Now here you can see this is more like and can you see that it is extending onto the scalp? And these smaller lesions, even a dermatologist might think of seborrheic dermatitis rather than a tinea infection in this patient, in patient number 1. Patient number 2, you can see that there are no well-defined lesions. It's mostly erythema and the scaling. Even in patient number 3, the edges are very unclear and you can see the steroid-induced acne. So this patient was not someone who has used a combination, but this is someone who has used a steroid-containing whitening cream. You can see that again, right? The whiteness of the face. So this is tinea incognito phase, which is becoming more and more common, and it is very likely that you may miss these patients because unless you have a very high degree of suspicion and a trained eye, you are likely to miss this. One important tip that I would like to give you is if your patient has a itchy rash in the face, especially involving like more or less the pan facial, You may see it better if you go a little bit away from the patient. Keep a distance from the patient. If you go too close, you may not see the pattern, right? Once you see the pattern, then you can go closer and look for scaling, right? And again, one very difficult area to diagnose is the hand. When you have this sort of scaling in the hand, you would think of eczema of the hand and start them on potent topical steroid. Similarly, this lady with this breast lesion, you can see that the demarcation is there, the scaling is there, but it's very likely that any one of us, even a dermatologist, would give this patient a steroid thinking of nipple eczema. And also there is a chance that you may refer this patient for scans and mammogram and everything because it's a unilateral nipple eczema, right? Some more cases. Now this is called the pseudo-imbricata pattern. You can see the wood grain kind of presentation, and then again you can see the slightly elevated active border, right? And here again you can see the tinea incognito here and the steroid-induced triad. This was due to a clobetasol, gentamicin, and miconazole containing triple combination, which is now taken off the market. Right? You can see that in spite of giving this patient a permanent side effect, still the tinea is thriving. Right? So now the patient has, instead of one problem, the patient now has two problems to sort out, the tinea as well as the stripe. And remember, this is a young girl. So if she were to wear a sleeveless dress or a strap dress, this would be clearly visible, right? So now you know why we have to be very careful on managing tinnias. So I would like to give you some tips on the management. Number one is avoid using steroids or combination of steroids. If you are not sure of the diagnosis, treat the possible infection first, right? Itchy flexural lesions should be managed as tinea first. For your purposes, itchy flexural lesions, whether it is submammary or axillary or groin, treat as tinea first. There are a few differential diagnoses, but there is no harm in giving a topical antifungal. Even now, even in my practice, if I'm not sure of the diagnosis, this is what I do. I explain to the patient that this could either be a tinea or eczema. But if I treat a tinea with eczema treatment, that the patient might run into more trouble. So I'm taking the safer option. I explain and give it. And usually my practice is to get them down in 2 weeks and see how they are responding. So this is something you also can practice, right? Remember, combinations are not wonder drugs. It's a steroid that works. You saw it, right? You saw it here. Now this is, if you all can remember, there was a brand called Sonoderm GM. So this lady has used Sonoderm GM, and you can see that this combination didn't do anything for the tinea, but it also gave this patient a serious permanent side effect, right? So you don't need to know anything. If you remember that picture, you will never insult yourself by using a steroid on a tinea. When you want to choose an antifungal agent, choose the appropriate one. Remember the small chart that I showed you. Please don't start somebody on glycofulvin if they are having pityriasis versicolor or even a candida, right? So the college, the Sri Lanka College of Dermatology and Aesthetic Medicine guideline on management of tinea we recommend the use of only topical antifungals, only if the tinea is involving one region only, right? And also if that is a naive tinea. What do I mean by the word naive tinea? A naive tinea is a tinea that has not been tampered with by the use of steroids or other medications other than antifungals, right? But if it is extensive tinea, unresponsive tinea, and tinea of the face and scalp, definitely has to be treated with oral antifungal agents. Something that I forgot to mention when I talked about the change in organism is this Trichophyton indotineae or Trichophyton mentagrophytes genotype 7 is now increasingly being recognized as a sexually transmitted infection because it is seen in amongst sexual partners and also exclusively in the groins, right? So now there is actually some evidence to, call this infection, the groin infection due to Trichophyton indotineae, as a sexually transmitted infection. So again, the take home point for us is if you have a sexually active person having tinea of the groins, it is not only that person who has to be treated, their sexual partner as well, right? So combinations of steroid, antifungal and antibiotic, triple and double combinations, what is the legal situation at the moment? Remember, all triple combinations are banned in Sri Lanka, right? At the moment, there shouldn't be any triple combination in the market. So if you were in the habit of using triple combination, please don't think about adding 2 or 3 things together and giving the patient. Please don't do that because we took the triple combinations out of the market for a reason. It's been a 6-year battle, right? The first letters were written when I was the president of the college in 2019. So for the past 6 years, we have been battling to take these out. And from in the entire South Asian region, we are the only country who have been successful in doing this. So please help us. Like this was not an easy thing. And please help us by not, trying to prescribe these things or trying to make up your combinations. When it comes to double combinations, the antifungal and steroid double combination is allowed only for mild steroids. So that is hydrocortisone only. So all these other things, the B combinations, I will tell you one name because Candid B is still in the market. They all should be out of the market by now, right? So this decision to take double combinations off the market was taken about 2 years ago. Right? Triple combinations decision was taken in 2019, and again about two to 3 years ago, the decision to take the double combinations was also taken. So the only combination that is now allowed is hydrocortisone plus antifungal. And but I know that certain combinations are available, especially the locally manufactured ones, right? I will mention the household name Candid B, right? There were like this, there were some very potent, highly active combinations like Candid B, Travacoat, right? And there are imitations of these combinations in the market. Mostly these are manufactured in the Sri Lankan by Sri Lankan companies. Therefore, take like now if you're sort of importing it, then it can be stopped. Imports can be stopped. But if you're manufacturing it, the the NMRA's hold on stopping that is much less because there is no custom clearance for locally manufactured. But please don't go for these clotrimazole and beclomethasone combinations that may still be available in the market. But then we have this, we can't be happy because now we have this menace. How many of you have seen this or used this? This contains clobetasol, one antiseptic, two antifungals, and one antibiotic. So if the NMRA is not authorizing double or triple combinations, will NMRA authorize a penta combination? Right? If you think about prescribing this, just stop and ask yourself this question. So this combination is not coming into the country through legal means. Okay. So the problem is now all these legally imported products, or I mean, mostly the imported products, it was easy to take them off the market because there is a recognized, registered local agent with the NMR. But when it comes to this menace Dermi 5, there is no local importer. There is no legal way of bringing it into the country. Even this picture that I'm showing you is I took it from my WhatsApp conversation with Dr. Savin Semage when he was the CEO of the NMRA. So with our repeated complaints, they did some raids, and this is from one of those raids, right? So this is a picture that Savin sent me. But unfortunately, raiding all the pharmacies in this country is not something that the NMRA can do. So it's up to us. I will just share two stories about Dermify, my horror stories. One is there was this well-educated English-speaking lady. I think she also was an executive. She had either bought or given this Dermify by a doctor. So she has used this for a tinea, and I treated her for recalcitrant tinea 2 or 3 times. There was a time that I dreaded seeing her name in the patients list in the private sector, right? Because I was wondering, what can I do for her now? I think she must have spent more than 5 lakhs of rupees for this tinea alone. Because there were times that I had to put on expensive brands of itraconazole double dose for 3 months. So 400 milligrams of itraconazole per day for 3 months, right? So you can do your own calculation, right? So that is one story. Story number 2 is a 21-year-old patient who had been prescribed this by a doctor, and he felt better. So he took it again and again and again. He said there are about 20 empties of this same thing at home. Unfortunately, he is having exogenous adrenal suppression with large, huge striae, purple colored striae in his lower abdomen. He's only 22. And now I have been following up for about 6 months. Still, his adrenal suppression has not gone back, and the hydrocortisone dose given by the endocrinologist has been increased. So now his tinea is also not getting better because now the endocrinologist is giving him oral steroids because of the damage that was done by this topical clobetasol. Right? So don't think that ඕක මේ ගාන cream එකක් නේ ගණන් ගන්න ඕනේ නැහැ. No, it is not like that. Especially if you apply clobetasol to a groin lesion, especially the scrotal area. The absorption of anything in the scrotum is about 40 times the absorption that you would have in the forearm. Right? So anything that you apply on the groin of a man, just the groin, it's very likely to get absorbed through the scrotum, even if you don't apply it on the scrotum. Right? So you will see that applying creams is not a simple thing, right? There are so many things that you would not consider, right? So and also remember, this is not registered. So if you prescribe, you are doing something illegal, right? And if we are, as dermatologists, we are in the habit of complaining to them in MRA very, very frequently if we see people using Dermifide. And if there's a prescription, that will also go to the NMRA, right? So please don't get yourself into trouble. Okay. The most important thing. What are the agents to select? Miconazole and clotrimazole, the response is not very good, but in the clinic, the only thing that is available to us is clotrimazole. In another 2-3 years' time, miconazole may again become more responsive because at the moment we don't have miconazole in the hospital. So the use of miconazole is much less. So after some time, miconazole may even become useful. And remember, if one brand is not giving improvement, don't switch brands. Yes, the brands that you switch are going to be more expensive than the brands that you used earlier. Midfield ointment may still be useful. One thing, one thing is Whitfield ointment is useful for extensive disease. Secondly, it has a very good keratolytic action. So the scaling will be less, right? So at the moment, the agents that we may use safely are ketoconazole, the topical agents, right? Ketoconazole, terbinafine, iconazole, very few brands are available, cyclopirox, amaralfine, and the new one is luliconazole. Please, please don't think that either amaralfine or luliconazole or cyclopirox can be used as a monotherapy. I have seen enough patients who have been started on luliconazole by non-dermatologist as a monotherapy and like nothing happens to the rash. So my advice to you is please combine 2 antifungals. Don't use monotherapy. Use 2 topical antifungals, either ketoconazole and terbinafine or terbinafine and cyclopirox or whatever, right? We don't have enough evidence to say that this particular combination works well. So I also try different combinations. My principle is like if the GP has used miconazole, I will go for something else, right? Obviously. Not because I want to use something else, but the patient comes to me because they have not got better with the GP's treatment. So when it comes to advising the patient, this checklist, apply the cream over the entire lesion and about 1 inch around because you have the organisms growing out. That is why you get the ringworm, right? So on the patch and around the patch. I usually draw that on the prescription sheet. Then local applications are best continued for 4 weeks after apparent clearance. So if it takes 6 weeks for the patch to disappear, you have to add another 4 weeks of local application, even though the rash is not there. I usually, when I write a prescription, especially in the private sector, when I prescribe the antifungals, I will write 3 months or masa tunai in the prescription itself, so that the patient will not have the chance of coming back and telling me, Dr. Mata kiwe me tube එක ඉවරුනාම ගන්න නවත්තන්න. Right? So those things don't happen. If they stop it, it's their own funeral, not mine. Right? So my usual practice is to think of a fixed duration, 3 months. Emollients may help, especially in scaly lesions, right? Especially if they have a dry skin, very dry skin, I usually put them on emollients as well. And then also topical tretinoin cream may be used as a keratolytic agent. Similarly, there were some creams containing benzoic acid, right? That also is a keratolytic, but I'm not sure whether it is available in the market now. And remember, like in scabies, all affected family members have to be treated, and management of fomites is important. This is more like a scabies management now, right? And dermatophytes are destroyed by heat only, right? So using antiseptics or soap will not help. So what I tell my patients is either boil your clothes or iron them, right? Especially the underwear and the towels. And in case of tinea faciae or tinea capitis, don't forget the pillowcases, right? Then again, the use of cotton clothing, avoidance of tightly fitting garments. Actually, there is one school of thought saying that our change in garments has also contributed to this tinea epidemic. Like, irrespective of the gender, most of us are now in trousers, and we wear them for 12 hours, 14 hours a day. Secondly, most of our young girls are in the habit of wearing what they call these tight shorts. Even under their school uniforms, they wear tight shorts. And most of the cheaper tight shorts are made of nylon garments. Okay, so you have to make sure that you use garments which are lightly fitting and minimize sweating. Another thing now in today's context is now probably we will see an increase in tinea infections island-wide after the current disaster. Okay, the wet environment. You find it very difficult to, all these advices that we give to our patients, they don't hold in the current scenario of a huge number of patients being in refugee camps, concentration of people, very few sanitary facilities, water is scarce, right? And you have to, like, most of these people who left their homes with only a few items of clothing, they may have to wash and reuse their underwears very frequently. And the chances of them, ironing them or boiling them or even getting them dried in hot sun are very less. So therefore, again, I think we will have to be ready for another huge surge in tinea infections in the next few weeks and months. Okay, so I think again we have to be very, very vigilant about this. Remember, it's going to happen, right? And make sure that we don't abuse or, mistreat these patients. Please, please, any fungal infection, only use topical and only use pure antifungals. Don't add steroids. Right. So, what are the oral antifungals that you can use? At the moment, itraconazole and terbinafine are the drugs of choice. I use glycofulvin not as monotherapy, but together with terbinafine. So I have never used fluconazole for tinnitus. Itraconazole, the dose is either 100 milligram BD or 200 milligram daily, and you have to give it for, I usually give for 6 weeks now. Remember, don't combine itraconazole with PPI. I usually don't promote specific brands. I try not to do that. But the brand may be important in case of itraconazole because some brands may have, remember, itraconazole is not a powder, it's a liquid. So if we are to administer a dose of 200 milligrams of a liquid, you need to have a very large volume of liquid. Therefore, to make it into a capsule, what they do is it's the pellets that are being dipped in itraconazole liquid and then put into capsules. So you know that if there are larger pellets, or if only a few pellets are being dipped in the liquid, and like if there are dummy pellets or larger pellets, the dose that is expected will not be delivered, right? So that is an issue with some of the cheaper itraconazole brands, but there are some itraconazole brands that claim that they have this bioequivalent certification. So if you want to go for a cheaper brand, go for one of those. And another thing you need to remember in case of itraconazole is itraconazole has a lot of drug interactions. It cannot be given in patients who are on immunosuppressants, most immunosuppressants, and also in HIV patients, the antiretrovirals have drug interactions with itraconazole, and the other very important group is the patients who are on antipsychotics, right? Even risperidone cannot be given together with itraconazole. Therefore, if you want to prescribe an oral antifungal, I always try to get a list of medications that they are on, and I just Google drug interaction checker. My preferred site is WebMD drug interaction checker. Go to one of those, check for interactions, and then prescribe. If you do that, the patient, and then I always tell the patient, and also I make a note that I have checked for interactions. Because otherwise they might come and tell you, doctor මේක ගත්තට පස්සේ මට අරක වුණා මේක වුණා, right? So remember those things. Then when it comes to terbinafine, even though BNF might say 250 milligram daily, that dose is useless. So we go for the 250 milligram twice daily dose, again 4 to 6 weeks, right? So that is the oral treatment, right? So there are some important things that you need to remember. All oral antifungals are potentially hepatotoxic. So please, if you are prescribing antifungals for more than 2 weeks, which you have to do in case of tinea, please check their liver functions. All oral antifungals are contraindicated in pregnancy, but terbinafine may be used if the risk outweighs, if the benefit outweighs the risk, especially in the second or the third trimester. I have used terbinafine in mothers who have very severe tinea, extensive tinea, especially because unless you get rid of that during pregnancy, you cannot treat during breastfeeding, right? So when the baby is born, the mother will have to only resort to topical antifungals And there is a very high risk that the baby also will be infected while breastfeeding. Therefore, I try to get the infections under control as much as possible during the pregnancy. So if you are, for your purposes, even though you know that it can be used, I would rather you not use it, right? Let us take that decision because the VOGs will not be happy. Also remember, if you are giving somebody griseofulvin, you have to ask them to use condoms. BNF advises men to avoid fathering children while on and for 6 months after using griseofulvin. How many of you knew that? Hmm? Some of these affect the OCP efficacy via cytochrome P450 pathway, so especially itraconazole. So, that is a very tricky situation, right? Somebody who is on OCP, you think are okay, they are on OCP, they will not get pregnant, and you give itraconazole, and the OCP's efficacy goes down, and she gets pregnant. Okay. So in such instances, I think it's better to ask them to go for double contraception. Some of these need dose adjustments in renal impairment. So you can see that prescribing antifungals to somebody is not a simple issue. It's a decision that you have to take with a lot of things running in your mind, right? So take your time. Ask about the medications that they are on. Don't just prescribe this and forget all the other co-medications that they may be on, right? So let's be extremely responsible when we are managing tinea infections, right? When it comes to tinea capitis, please don't try to go for IND in case of a chorion, right? Even without IND, risk of scarring alopecia in chorion is very, very high. For either tinea capitis or chorion, oral therapy is essential. Griseofulvin 10 milligram per kg per day. Very rarely we use oral steroids in case of inflammatory tinea. Again, please don't do this on your own. Send the patient to a dermatologist. When it comes to local agents, only 5% cetrimide shampoo, right? Don't use anything else. It's very difficult to apply antifungal creams on the scalp because of the hair, right? Versicolor treatment, topically, you can use Whitfield, selenium sulfide lotion, ketoconazole cream or shampoo, or terbinafine. Terbinafine cream can be used, but not oral terbinafine. When it comes to oral therapy, your favorite fluconazole can be used, but at a dose of 50 milligram daily, or itraconazole 100 milligram BD for about 2 weeks. When it comes to genital candidiasis, we are very fond of the stat doses, fluconazole 150 milligram stat or itraconazole 200 milligram BD for 1 day. But don't forget the partner has to be treated, whether it's, if they're sexual active. Vaginal pessaries are effective as topical agents. And if there is recurrent infections, think about predisposing factors like diabetes, broad spectrum antibiotic use, pregnancy, OCP use, partner or other skin sites harboring the infection, and also the frequent use of harsh detergents. What I see is most of these young girls who come with recurrent candidiasis, they are ultra clean. That is why they get it. Again, the reason being, candida can colonize if the lactobacilli is not there in the vagina. So if you use too much of soap or harsh chemicals to be ultra clean in the groin and the private areas, you are increasing the pH in that area, and it is essential for lactobacillus, the survival of lactobacillus, it's essential that the pH remains at or below 4.5, 5.5. So if you use too much of soaps, what happens is you are increasing the pH, just sending away the lactobacillus and asking the candida to come and colonize. So that is why you should not use harsh detergents. Right. When it comes to onychomycosis, we either use terbinafine 250 milligram daily for 6 weeks in fingernails or 12 weeks in toenails, or itraconazole pulse therapy 200 milligram BD weekly pulses, 2 pulses for fingernails or 3 pulses for toenails. In all these instances, make sure that you monitor their liver functions. Don't forget that we have so many patients who have fatty liver in the community. When it comes to topical agents, unfortunately, nail lacquers are not available in Sri Lanka, but there is some talk that amaralfine nail lacquer will be available shortly. Miconazole tincture is again out. So at the moment, clotrimazole or tolnaftate lotion or 3% thymol in spirit are our only bets. But then those have to be applied underneath the nail, not on the nail, because none of these will penetrate the thick nail plate. All these topical agents have to be continued for 6 to 12 months to avoid recurrences. So I think that's all for today's lecture. So the take-home messages are: superficial fungal infections are common and becoming commoner in Sri Lanka. Treatment non-responsiveness or resistance is common. And you need to pay attention to the choice of appropriate antifungal agent, the duration of therapy, and ensuring compliance. Be aware of cautions in pregnancy, breastfeeding, and potential hepatotoxicity. Right? If you want to use some of these things as your educational material, these are available at the Sri Lanka College of Dermatology's website, right? Or the Facebook page. Thank you. Are there any questions?
Yeah, thank you very much, Dr. Indira, for that excellent and updated presentation on superficial fungal infections. The way you combine clinical pers with the latest research evidence made the session exceptionally valuable and immediately applicable to our practice. Actually, about these combination preparations, the highlight was very, very important because it is being abused by most of the time in primary care. So we truly appreciate your time and your willingness to share your expertise despite your many professional commitments. Now, I went through all the questions in the chat box. Actually, you have answered all of them, except few. One is asking about what is in the pediatrics, what oral antifungal could be used. That is one question that was unanswered.
Yes. In the pediatric practice, what the LRH practices is using fluconazole, because neither itraconazole nor terbinafine can be used in children less than 6 years of age. So they use fluconazole in spite of it being mentioned as not very effective against dermatophyte infections. But when it comes to tinea capitis, griseofulvin is the drug of choice. And it can be given in children as young as 2 years.
Okay. There is another question. Can we combine two oral antifungals? Example, daily itraconazole with weekly fluconazole?
I would rather not use weekly fluconazole. I mean, if you speak to a mycologist like Dr. Primali Jayasekara, she would tell you not to do that, right? We may be just wasting the patient's money, but my preferred combination is griseofulvin and terbinafine, especially not as a first line treatment. I mean, if I want to give terbinafine, I would give it as a monotherapy. But most of the patients who come with non-responsiveness or after several courses of itraconazole, then I combine the two, right? But I think that sort of combinations are best left for a dermatologist because you are using two potentially hepatotoxic drugs for a long period, needing a lot of monitoring. So, I mean, those are things where, I mean, I think for a GP, you're uh, like you should think of referring a patient to a dermatologist or to a dermatology clinic early if your tinea infections are not responding well. Okay.
Yes. Another question now, when it comes to tinea pedis, very
Hmm.
resistant sometimes. So, what is the best way we can treat tinea pedis infection?
Tinea pedis, Maitri, I think the main reason for that is the niche is there, right? Because most of these people who develop tinea pedis, either they are wet workers or they have diabetes or they have these stubby toes where the toes are like this. There is no space between the toes, right? So there is always a chance of moisture getting collected. And also the use of prolonged use of occlusive footwear. So there is some sort.
Dr. Indira, are you with us?
Yeah, yeah.
Yes.
Yeah.
Yeah, yeah,
There was a
yeah.
interruption. Yeah. Yes, Maitri. Any other questions?
Thank you, Indira. That was an excellent presentation. Shavali here. I
Yes,
was able to
Shamali. Yeah,
do. There was
yeah,
one question about
yeah.
using soap modulations.
What?
Uh, soap.
Yes. So,
Yeah.
yes, there are so many antifungal soaps. But again, the current understanding is that antifungal soaps are not very useful because, I mean, it's a short contact therapy. Now, with all these resistance coming in, short contact therapies are not encouraged. And also remember now especially for a primary practice, the GP practice, or even for our private practice, treating a tinea is a very expensive exercise. So you have to make sure that you use the minimum essential number of medications. That is the other thing. So even an antifungal soap will be like the minimum cost would be 400 rupees or more, right? So using soap is not an issue. The only place where I would discourage using soap is in case of recurrent candida vulvovaginitis or I am mostly the vulvovaginitis, right? Because of the reason I explained. The more soap you use, the higher your vaginal pH and the higher the chances of candida getting for colonization of candida. So, I mean, I'm not very particular about soaps. What I tell them is you use whatever soap you have been using. Because keeping clean is important. Any other questions?
There was one
Sharp.
question.
Yeah.
Band-aid use over tinea patches. I think we don't recommend, right?
What?
Band-aid.
No, we don't recommend. It worsens the occlusion, right? Sweating, occlusion.
Yeah, Maitri.
Yes. So, as there are no further questions, on behalf of the college, uh, we again thank Dr. Indira Kahawita for her time and for your insightful presentation and for enriching our clinical knowledge. Thank you so much.
Yeah, thank you, Maitri and Shamali both. And sorry for taking so much of time. I mean, we took almost 1.5 hours.
Yeah, that was
Okay.
very useful. Practical
Yeah.
tips.
Right. Okay. Thank
Thank
you. Good night,
thank you so
everybody.
much. Good night.